As usual with those questions, the answer is it depends. When you measure radiation exposure, you're going to use units like the sievert to get an idea of biological exposure and biological effects. The sievert as a unit is a very high range of exposure. The sievert, if you're exposed to one sievert, it means you've been in a nuclear disaster. You'll get seriously sick or die short term. And typically what patients are exposed to for a single procedure is in the range of the millisievert, of 1,000th of that. Typically, an operator for one single procedure will be exposed to 100th of that 1,000th of that sievert, so about 10 microsieverts. Of course, it highly depends on the type of procedure, whether you're implanting, for example, a pacemaker close to the radiation source or performing a procedure through the groin shielded with a cabin. But for a single procedure, that's pretty much the order of magnitude. Of course, if you're going to do this as a career, it's going to add up over your lifetime. Typical exposure rates for an operator are again in the millisievert range, and occupational limits for maximum allowable exposure are around the hundreds of millisieverts. For example, Germany has a law limiting maximum lifetime exposure to 400 millisieverts. Clearly, the risk we're talking about is the risk of developing malignancies, the risk of developing cancer. And this risk is called stochastic, meaning that there is no predefined safe threshold. We actually don't know what amount of radiation is safe. Obviously, we're all being irradiated right here as we speak. And at some point, this becomes dangerous, and we actually don't know beyond what level we should consider it safe or unsafe. But what we can clearly see is, for example, if you compare interventional cardiologists to non-interventional cardiologists working in the same hospital, doing the same type of work, the only difference is one works in the lab next to ionizing radiation, one doesn't, you can clearly see that the individuals working in an interventional setting have a greater risk of developing fatal cancer. The simple answer is people are monitored. We all wear these dosimeters that collect the radiation we're exposed to get an idea of our cumulative exposure over days and weeks and months and years working in the lab. For individual procedures, and in particular for optimizing our workflows, we can do a lot of other things. We can really try to do real-time measurement of radiation, put different electronic dosimeters on different spots around the patient, for example, and also we can do simulations. We can actually use a software that was developed to simulate nuclear weapons, to simulate nuclear explosions, has been transformed and made available to use in simulating radiation exposure. And we can use that to try and understand how radiation affects different parts of the body in different positions in different procedure types. There's different things you can do. The very intuitive answer is use less of it. Use less radiation, meaning use less fluoroscopy or X-ray time. That's very intuitive. If you cut your X-ray time by half, you will reduce your exposure by half. The other, maybe less intuitive approach, but far more efficient actually, is to reduce the amount of energy, the amount of radiation per unit of time. This means you're going to degrade your image quality. But typically the image quality is far too good. It's way beyond what you need. And once you realize that you can actually cut down the image quality and thereby reducing the radiation exposure dramatically, you can actually keep your radiation time or decrease it a little bit and reduce the image quality a lot and thereby make impressive gains in your personal exposure and the exposure to your patient. Also, apart from the things you can do yourself in the lab, the technological advances that have helped us a lot in the last 5 to 10 years have been in the field of multimodality imaging, of image integration actually, where we've been able to use a lot of tools that are available to visualize our catheters, 3D mapping tools, localization tools, tools to help us understand the orientation of a TE probe, for example, and integrate these in the existing fluoroscopy systems. Because everybody likes fluoroscopy and it's logical, it's intuitive, everybody understands how it works, and it gives you valuable information. You just want to use as little as possible of it. And by combining these technological advances and integrating them into what you know, into the framework you know, you can typically start performing procedures with spectacularly low amounts of fluoroscopy and spectacularly low amounts of radiation.